Hi, my name is Dr. Warren Fingrut, and I'm a research fellow with the Sloan Kettering Institute. My mentor is Dr. Juliet Barker of the cord blood transplantation program with the adult BMT service at Memorial Sloan Kettering Cancer Center. Our analysis that I'll be presenting today is analysis of 372 adult allograft recipients reveals associations between non-European ancestry, low socioeconomic status, and receipt of HLA disparate grafts. I want to thank the co-authors as well for all of their important contributions to this work. The background to this project is that racial, ethnic, and socioeconomic status disparities both impact patient care in bone marrow transplantation. We have shown in a recent publication in Blood Advances that there are racial and ethnic disparities in access to optimal donors across each donor allograft type. And furthermore, there are other researches that have shown that there are socioeconomic disparities in access to transplant. Furthermore, there are additional researchers as cited below that show that there are racial and socioeconomic disparities in post-transplant outcomes. However, the relationship between ancestry and socioeconomic status and their interaction with donor type are unknown. Therefore, we hypothesize that low socioeconomic status disproportionately impacts non-European recipients of HLA-mismatched transplants. And when I say HLA-mismatched transplants, I'm specifically referring to cord blood, haploidentical, or mismatched unrelated donor grafts. The challenge with doing an analysis like this is that household income is not routinely collected at many centers, including our own. And so we analyzed surrogates of low socioeconomic status, the relationship between those surrogates and ancestry and donor type in over 370 patients who received a bone marrow transplantation over a 2-year period. These surrogates of socioeconomic status included neighborhood poverty, in which we defined a low socioeconomic status if the area deprivation index was greater than 60%, Medicaid as primary insurance at time of bone marrow transplantation, or patients who received financial support for cost of living and or medical expenses within 6 months of allogeneic transplantation. And we found that looking across these 4 surrogates of socioeconomic status, that 5% of patients had were living in a neighborhood with low socioeconomic status. 6% had Medicaid insurance. 14% received medical expense support, and 19% received cost of living expense support. And you can see from the diagram on the left that on the top are the 4 different surrogates of socioeconomic status, and you can see the relationship between each of them in terms of where a patient started and where a patient ended. And the bottom line from this information is that different surrogates of low socioeconomic status describe different subsets of patients. And here, only 37 patients had low socioeconomic status by at least 2 of these measures, but only 5 by 3 and none by all 4. Next, we evaluated the intersection of ancestry and socioeconomic status with donor type. And on the left, first we analyzed just the impact of ancestry on socioeconomic status, and we found that twice as many non-European patients relative to Europeans had Medicaid insurance or were receiving either type of financial support, and those who were granted support received a mean of 40% more in funding per patient. And then in the table on the right, we analyze the intersectionality of ancestry and socioeconomic status with donor type, where you can see that for this analysis, we combined all European ancestry patients together because there were few European ancestry patients who received HLA-mismatched grafts. However, when we compared European ancestry patients to non-Europeans who received HLA-mismatched grafts, you can see that that cohort was the most likely to have low socioeconomic status across each surrogate. And these data show that the most vulnerable patients, non-European ancestry patients with low socioeconomic status, are receiving the most specialized transplants, HLA-mismatched transplants, that require the highest levels of care. The implications of this work are that interventions to advance equity will require better socioeconomic status classifications, including detailed recording of household income, and that successful extension of transplant access to patients from underserved populations will be contingent upon addressing this financial hardship. The next steps for this research are prospective interventions, which are warranted to mitigate financial toxicity. And these efforts are extremely important and increasingly important, given the increasing diversity in the United States, with patients from underserved populations also being more likely to be from underprivileged groups.